Okay. Okay, so I think we'll get started now. So good evening, everyone. Welcome to this third session in our Epilepsy Ontario's educational webinar series. My name is Rosalind Werner-Arce. I'm the Executive Director of Epilepsy Ontario. Over the coming months, we will be offering a series of webinars on various topics related to epilepsy. Tonight's session is called Understanding Epilepsy Treatments. So I have just a few housekeeping items before we get started. Your phones have been muted so that we aren't distracted by any background noises. If you have questions, please type them into the chat box that you'll see at the bottom right corner of your screen, and we'll do our very best to answer them at the end. And if you're having trouble logging in, just make sure that you sign in as a guest. You don't need a login ID or password. And just a reminder that we are recording tonight's session and we will post it on the website in a few days. So moving on, I'm very pleased to introduce our speakers for this evening. We are very fortunate to have such experts in epilepsy with us tonight. Our first speaker is Dr. Rick McLachlan. Dr. McLachlan is Professor of Neurology at Western University in London and previous Director of the Epilepsy Program and EEG Department at London Health Sciences Centre. He has also practiced medicine in Australia, New Zealand, and more recently, Abu Dhabi. Our second speaker is Maria Zach. Now, Maria is stuck in traffic because this is Toronto and that's what happens. She is hoping to join us later on in the webinar. So I just would like to speak to Maria's background. She's a pediatric nurse practitioner in the Division of Neurology at the Hospital for Sick Children. She works in the epilepsy program, specifically with children with intractable epilepsy, genetic epilepsies, and children in the epilepsy diet program. Maria is also cross-appointed as an adjunct clinical faculty at the Lawrence S. Bloomberg Faculty of Nursing at the University of Toronto. Now, our last speaker would have been Dr. Tawfiq Valiente. Unfortunately, he's not going to be able to be with us this evening due to some surgery scheduling problems, but we are going to figure out a way for him to record his session, and we'll add it on before we post the session to the website. So at this point then, I would like to pass it over to Dr. McLachlan to take it away. Dr. McLachlan?
Thanks very much, Rosalind. Happy to be here. Good evening, everybody. I was asked to talk to you about anti-seizure drugs, something I suspect a lot of you are quite familiar with in one way or another. Since Dr. Valiente in surgery isn't going to be here, and maybe Dr. Zach may or may not be here, at the end of this, I'm quite happy to answer questions about drugs as well as any other aspect of epilepsy management. I've been around a long time, so I think I can cover most areas that you might have questions about. So let's just start here, if I can run these slides. As I said, that's what I'm supposed to talk about, drug treatment of epilepsy. This is a huge area, and we could sit here all night discussing various aspects, but what I'm going to do is try to give you just an overview of the approach to drug management of seizures. So let's start by looking at what we would ask for if there was an ideal drug for treating seizures. First of all, you want a drug that works for all seizure types. As you know, there's many types of seizures and many types of epilepsy, so it'd be nice to have one drug that was a cure-all for everything. Secondly, it would also be very nice to have a drug that didn't have any side effects. As many of you are aware, this can be a big problem when you take medications for seizures. Thirdly, a drug that was easy to use would be beneficial, once a day dosage or even once a week dosage. And then finally, for a lot of people anyway, especially those that pay for their own drugs, it would be great to have an effective drug that didn't cost very much. Unfortunately, I'm not aware of any such ideal drug. This picture I put on here is actually a pharmacy in West Africa, so maybe hidden in all those things on the table there is such an ideal drug, but if it's there, I certainly don't know about it. So what principles of drug therapy is the doctor going to use to give you something that's in your best interests? Well, first one I put on here is that monotherapy or treatment with a single drug is what we aim for. Unfortunately, there are a lot of people with epilepsy where treatment with a single drug is not effective and we have to use more than one. The reason we aim for so-called monotherapy is because the more drugs you have to take, and also the higher the dosage, the more likely you are to have to deal with side effects. So all drugs, no matter which one you pick, is going to have its own set of side effects, some more than others. But the more you take and the greater the number of drugs that you take, the more side effects you're likely to have. So we aim to try to have people just on one drug. The third thing I put on here is drug levels. So when you go to have blood taken to look at the level of some of the drugs, not all of the drugs can we do blood levels in, but a number of them. I was around when this started back in somewhere around 1980. Drug levels began to be used widely, and we all viewed it as a really good thing because now we have a very nice guide of where we're at when we're giving different doses of a drug like, say, carbamazepine. We know that the so-called therapeutic range, the range of the drug in the blood that's most effective for controlling seizures and least likely to give side effects is such and such. So the doctor will try to dose the drug to get the blood level in that range. It all sounds like a great thing, but unfortunately it hasn't turned out quite as effective as we thought it would. And the reason for that is because the so-called therapeutic range that the doctor uses to try to get the level into is an average range from a whole bunch of people. And as an individual, your own personal range may actually be higher than that average range or lower than that average range. And if you're outside of that average range and the doctor is trying to push you into that range, you might end up having problems with either seizures or drug side effects. So this is only a guide, and you have to use it when you do use it with looking at the important clinical information, which is whether the person is having seizures or side effects. In Canada now, we've got more than 20 anti-seizure drugs to choose from, and I've listed many of them in this table. They're classified into the old and the new, and the difference between those two categories is that the old drugs came on the market before 1990, and the new drugs after 1990. And they're still coming out. The bottom three, the lacosamide, rufinamide, and perampanel on the right there, all have come on the market just in the last couple of years. And there are drugs being tested that will probably be coming on the market in the next few years as well. So there's always new drugs coming along. And the next slide, if I can find it here, here it is. This is a number of other drugs that are less frequently used. You might not have heard of a number of them. I'll bet you've heard of this last one, cannabis or marijuana, which has been in the news lately. These all have a certain degree of effectiveness in treating seizures. Now, with all these drugs to choose from, is any one drug better than the other in controlling seizures? Well, this question has been addressed many times through doctors studying one drug in comparison to another drug and publishing the results. And you might be surprised to know that out of many, many studies comparing many different drugs with other drugs, the bottom line is that there's little to no difference in the ability of these drugs to control seizures in general. There's a big but on that slide, though. When you come to any one individual, there can be very big differences in the response to these different drugs. We don't know exactly all the reasons why one person with, say, temporal lobe epilepsy and another person with the same kind of temporal lobe epilepsy have totally different responses to different medications. But I can tell you I've seen this happen many, many times. An example would be having two people with exactly the same kind of seizure disorder, and you put them both on, say, carbamazepine. One person goes off and is happy as can be, no seizures, no side effects, and the other person, it's a complete disaster. So we're very fortunate as physicians, and the patients are fortunate as well to have all these drugs to choose from. When you go to the doctor, how does he decide what drug to give you? Well, here's a slide that shows a whole lot of different factors that have to be taken into account when deciding which drug is potentially the best one for you. And I can't go through all of this, but I'll just give you a couple of examples. The cost of an anti-seizure drug is not terribly important for a lot of people. If you have an insurance plan or you're on disability, they will cover drugs for you. But if you're, say, a farmer who has to pay for his own drugs, you're not going to be too happy if I give you a drug and it's going to cost you $300 or $400 a month out of your own pocket. This slide just shows how the cost can vary, and the main factor that determines the cost of drugs is how long the drug has been around. This down along the bottom are different drugs, starting with phenobarbital in 1912, ending with Keppra or levetiracetam back in the late 90s. Other drugs come after that. But phenobarbital, for example, costs about $1 a month, compared to now a new drug like lacosamide that might be $300 a month. So cost is definitely one factor that can be considered for some people. Here's just another example of if you're male or female, it can make a big difference as to what drug you might be given. I often tell trainees that women being much more complicated than men, you have more of a problem treating their epilepsy than than men, who are much simpler beings. But with women, there's all sorts of issues that have to be taken into consideration, not least of which is when they become pregnant, and the impact of the potential impact of the drugs on the baby. So lots of issues that have to be taken into account when decisions being made of which drug to use. Up in the top here, the evidence-based medicine and rational polytherapy. These are scientifically based ways that the doctor might use to decide what drug you should be given. And these are from scientific studies of the drugs in people with epilepsy, and the results of those studies guide how or which drug should be used for treatment. I've been around long enough, and I've used both of these to know that it doesn't always work. So again, I will tell the trainees that I'll often resort to what some people call coin-based medicine, which is effectively, if there's two drugs we have to choose from, you flip a coin and pick one of them in a trial and error basis. That often works just as well as these other scientifically based means, and then with a big dose of common sense, and that's both common sense from the doctor and the patient, because the patient should have a say in this as well, and what drugs they're taking, how effective they are, and what the side effects. When all that fails, here I am in my clinic resorting to magic and wizardry as a last resort. Here's what we're trying to do when we're treating epilepsy. And this looks very simple, but believe me, it can be very complicated. And that is trying to gain complete seizure control, which should be the role of anybody, or the goal of anybody with epilepsy, to have no seizures, and at the same time be taking drugs that don't give any side effects. I often tell people I can control anybody's seizures if I want to, if I give enough drug, but you're not going to thank me for all the side effects you might get from that high dose drug. So the aim is reach a balance between the seizure control and the side effects. And it's easy in some people, but a lot of people I see, that's a real challenge. One other point about the big difference between the old drugs and the new drugs. As I said, they're all more or less equally effective statistically in controlling seizures, but they differ in how many side effects they produce, with the newer drugs in general causing fewer side effects than the older drugs. So by and large, we tend to now pick one of these drugs on the right side, at least to start with, keeping in mind that you as an individual may end up on an old drug like phenytoin if that happens to be the best one for you in particular. Let me just end with a couple of comments about stopping medication. We've talked about starting, but some people can get to a point where they can actually get off medication. We don't start thinking about that until people have been seizure-free for at least 2 years. You should never stop medication on your own, or you're asking for trouble. Always do so in consultation with your physician, neurologist, or epileptologist. And remember that if you happen to be driving, having your seizures controlled, that you probably should limit driving. Well, you should limit driving if you're going to look at going off medication. There's a whole lot more I could say about that, but just look at these figures here. This 1 in 15 should be in the red circle, but this 1 in 3 refers from this is data, these are data from a whole bunch of studies looking at people who went off medication after being seizure-free for 2 years. And what they found was that if you are in that category, you have a 1 in 3 chance of starting to have seizures again if you go off medication. You can flip that around and say, well, that means I've got a 2 out of 3 chance of not having seizures. So that's why we still do this. The figure here that should be over in the red circle, this 1 in 15, is the one that bothers me. That figure refers to people who go off medication after being seizure-free for 2 or more years and start having seizures again, and we can't get the seizures under control. So 1 in 15 people will go from a seizure-free state on medication to having problems with controlling seizures when they go back on medication and seizures start up again. So you have to be willing to take that risk if you're going to try going off meds after 2 years. So I think I will stop there, and I guess if Dr. Zach is here, she can carry on, or I can answer some questions.
I'm here.
Oh, okay.
I'm in my car. I'm just gonna pull into a parking lot. I'm in Whitby, so I'm just moments away from Sheridan Nursery, so I'm gonna pull in and just speak to my slides. Is that okay?
Okay. I guess you're an RN, not a doctor. Is that right?
I'm a nurse practitioner at Sick Kids.
Nurse practitioner. Okay.
Yeah.
But I'm sure you know as much as many of us doctors, having dealt with epilepsy.
Well, probably more. No, I'm kidding. No.
Yeah.
I'm just turning into the parking lot, so I'm gonna be able to speak more clearly. I apologize.
Okay,
I'll just 2 seconds.
So maybe, Marie, while you're doing that, I know that Dr. McLachlan, you were going to answer a couple of questions that were sent in earlier. Do you want to speak to those now?
Sure. Yeah, I guess Aaron wrote in some questions for Dr. Valiente about vagus nerve stimulation. I can respond to that since he's not here. The questions were regarding what kind of seizures does vagus nerve stimulation benefit, and who is eligible for vagus nerve stimulation. For those of you who don't know what this is a surgical procedure in which a pacemaker-like device is implanted in the chest wall, and rather than the stimulating wire going to the heart, it goes to a nerve in the neck, which is then stimulated day and night with the view to decreasing seizures, which it does through mechanisms that aren't quite clear. The treatment works for essentially all seizure types. The people who we tend to put these in, and we've been doing this here in London for over 15 years and probably have 50 or 60 people who have been implanted with vagus nerve stimulators. The people that we tend to use it in are people who have failed other treatment, both drug treatment and surgical treatment, or people who are not candidates for more standard surgical treatment such as temporal lobectomy. The effectiveness is not as good as many other treatments. It reduces seizures by more than 50% in somewhere around 20 to 30% of people. Maybe 5% will become seizure-free for varying periods of time. So yes, it is effective, but it's by no means a cure-all. A nice advantage as far as a surgical procedure goes is it's relatively safe compared to, say, different types of brain surgery that we do for epilepsy. So it is certainly a consideration if you're continuing to have seizures, particularly frequent seizures. Personally, I think the more frequent the seizures, the more likely they are to respond to vagus nerve stimulation. So if you're only having one seizure a month, it may not be so effective. But if you're having seizures every day or every week, then it's certainly a consideration if you've been on many drugs and they haven't worked, or you've had surgery and it didn't work, or you're not a candidate for surgery. That's all I have to say about that.
That's great. Thank you very much, Dr. McLachlan. So there are a couple of other questions. I'm going to suggest that we go to those questions after Maria does her presentation. So Maria, I can move the slides for you if that helps. Okay.
Yeah, and I actually have my slides with me so that I can see what I'm talking to. So I'm going to go to the objectives. And what I want to do is just really review the principles of diet treatment so you understand sort of the basis behind the diet, what the different diets are. And then we'll talk briefly about the different types of diets that they use for treating epilepsy. There's 4 different common types of diets that are used. And then we'll see who's suitable for diet therapy. And we'll describe the process of starting diet therapy, and then we'll learn a little bit more about some more resources, because this is a brief presentation and there's more information that you can tap into to get some more details. So the next slide, diet therapy for epilepsy. Diet therapy, it's really a medical treatment. It's even though it's called a diet, it's considered a medical treatment, and it's used to control seizures when seizures are difficult to control. And so what happens in this diet? In ancient times, they discovered when people fasted for religious reasons, if they had seizures, they stopped having seizures. And basically what they were doing is burning their own body fat. And the byproduct of burning your own body fat is you develop these ketone bodies. And over time, there was a doctor in the 1920s who sort of remembered this concept and decided to try and use this theoretically in a more practical format, because it's not practical for us to starve. So instead, he decided that feeding fat, a high-fat diet that you burn, that produces the byproducts, which forms the ketone bodies, would be helpful. And in fact, they found that it was very helpful. But the diet sort of fell out of popularity because there were the discovery of antiepileptic medications. And you can imagine that if you can find a pill that works and helps your seizures, you're going to go for that as opposed to doing a radical change in your lifestyle and eating. So it fell out of popularity, but was brought back into popularity. I think it was in the late 80s, early 90s when Jim Abram, who was a Hollywood producer, director, had a son who had seizures. He was doing some research because his son had surgery. He had all kinds of treatments with different drugs. Nothing seemed to work to help his seizures. So he found this diet. His son went on the diet, and he had an amazing response. And so he really made it his life's work to bring this back to the forefront as one of the choices for treating epilepsy. So in recent times, it's become more and more popular because we have evidence and research that has shown that it's really effective in helping manage seizures. And nowadays, it's primarily used right now in children, but it's becoming more prominent in some adult settings. And we're using it not as the last resort, but as second or third line treatments, because medications often, once they don't work, we try diet therapy. So I'm going to go to the next slide, the principles of diet therapy. There's just a brief, just a little diagram that just kind of shows you the principles of different fats, and they're just converted to ketone bodies. The next slide, what happens, these ketone bodies either cross the blood-brain barrier, we don't know. So the next slide, what happens, the ketone bodies either form acetone, acetoacetate, or beta-hydroxybutyrate, which are ketone bodies. And there's many theories that scientists have as to how this then causes seizure freedom. It's very complex. It's still under study, and there's sort of controversy about it. But essentially, the body just affects the way the body processes or uses fat. It could modify how the insulin or the metabolism burns fat mostly instead of carbohydrates. So the next slide, we have different types of diets. And there's 4 types that you're probably going to hear about when you hear about, primarily we call these the ketogenic diet. So these are ketogenic diets because they form ketones. There's the classic ketogenic diet, which we tend to use for younger children because younger children will eat fat. And it's composed mainly of, you eat regular foods, but you have to add a lot of fat. So it's butter, cream, mayonnaise, for example, that you're adding to foods. And it's a smaller quantity of food, and I'll have some slides coming up that actually show you the proportion of fat to carbohydrate to protein. You get just enough protein to allow for growth and a reduced amount of carbohydrates. And carbohydrates are the sugars that we find in all foods, so whether it's fruits, vegetables, or pasta, cereals, breads. So the next kind of diet is also a ketogenic diet, but it's called a medium-chain triglyceride oil ketogenic diet. So the difference between that and the classic diet is this allows you to have more food choices. So you can go into different, you can have some vegetables, some fruits, a little bit of milk with that. You can have a little bit of pasta or rice within proportion, and we'll look at a slide to see what the proportions are for that. And you're adding an oil, which is a medium-chain triglyceride oil. It's a modified oil, which helps to make ketones. And this, by taking this oil, this allows you to have more food. So the older children tend to go on this diet because it offers more food choices so that they're not as hungry. But you're eating regular foods, but you're adding oils to your foods. And then there's a modified Atkins diet. We tend to use that in adults and adolescents. It's like the Atkins diet, except you're eating a lot of meat. It's high in protein because those tend to be the lowest carbohydrate choices. You restrict your carb amounts that you take in, but primarily you're eating a lot of meat, and you have to add fat to that. So you have to like meat in order to go on this diet. But this diet is different from the first 2 diets because you don't have to measure and weigh your food. With the first 2 diets, you have to measure and weigh everything, and it has to be calculated, and it's directed by a dietitian who gives a diet prescription. And you work very closely with a dietitian to make sure that you're following within the parameters. There are no food holidays, so you can't have a day where you're going to slip a little chocolate bar because you can fall out of what they call ketosis and you can have more seizures. So this is a diet that's very, very strict, and you can't have any diet holidays. But there are options, very creative options in how to celebrate, and we have very creative families at the Hospital for Sick Children and throughout the province. And throughout the world, and they know how to make the diet more palatable and creative for their kids. And then there's something that most people have probably heard about. It's called the low glycemic index diet. And this is a diet that is, you're not eating foods that are high in carbohydrates where you're going to have spikes in your blood sugar. So you tend to have foods that, like the proteins, you have consistent levels of blood sugar, so your kind of insulin is not going up and down and spiking. We tend not to use this one as much yet. The first 2 types of diets are the primary diets, and we try and do the modified Atkins, but we're not using it as much. That tends to be used in the adult setting. So we'll go to the next slide. Now I can't see the numbers very well because they're very small, but on the left-hand side you're going to see what a typical diet is, what we all should be eating, and I think that's roughly 55% carbohydrate. What do I have there? Fat is
15.
15%.
Mm-hmm.
Some of us don't eat that much. Some of us are probably 55% fat, and 30% protein. And then when you compare it to the classic diet, you can see that the classic diet can be up to 90% fat. Sometimes you can have more fat. That's huge. And then you're going into, what do I have there? Is it 3%?
3 for carbs.
Carbohydrates? Yep.
Yeah.
And then 7% protein. So you want to have enough protein to allow for growth. Then we go to the next slide, and we're going to compare our typical diet, which is on the left-hand side, with the medium-chain triglyceride ketogenic diet. So on that diet, you can see that you have roughly about 71% fat intake, with help me out here, Roz. I think it's 19% carbohydrate. Yep.
Yeah.
And then 10% protein. And then we're going to go to the next slide. And again, now we're comparing the modified Atkins diet. So on the left-hand side, you have our typical diet and have the components of a typical diet. The modified Atkins, you can see a little bit less fat, 64%, but still that's a huge quantity. Then you have
6%
carbohydrates. Yeah, and then 30% protein. But you can have more. There's no restriction in how much you can eat. And that's the nice thing about this diet is that if you tend to be hungry, you can eat as much as you want. You're not fluid restricted. And you don't have to weigh and measure your foods, but you have to count your carbs. And that's the big difference in that diet. And then there's the next slide will show us the typical diet compared to the low glycemic index diet. And you can see the low glycemic index is not dissimilar to the modified Atkins. You've got about 60% fat, 30%, what do I have there? Is that protein or carbohydrate?
Yes. Protein.
And then the remainder is the fat. So when you go to the next slide, you see a whole comparison of all the different diets. So you can kind of see on if you're not into the pie charts, but you just want to see a regular chart, you can see how much carbohydrate each diet has, how much protein and how much fat, which kind of puts it into perspective. All of these diets, you have to consume a lot of fat in order to generate ketones and ketone bodies. And so the different diets, the way we select them depends on age, depends on how kids can have the diet. Some children are not able to eat by mouth because they have poor tone, so they tend to have G-tubes in their tummies, and you can give the diet through a formula, and typically we use like a classic ketogenic diet formula that way. And again, as I mentioned, the modified Atkins we tend to use for teenagers who have some choice in their diet. It's not as restricted. And then the medium chain triglyceride oil diet we tend to give to kids who are older who want more food choices. So the next slide, when is diet treatment used? And usually we use it in children with seizures that are not well controlled by medications and who have also been evaluated to determine whether or not they're a candidate for epilepsy surgery. That's really important to do. And typically we say a child is not responding to medications if they've tried 2 antiepileptic drugs at adequate doses, appropriate doses, and they haven't had any seizure control with that. There's also certain metabolic conditions that you have to go on that. This is, for example, glucose transporter deficiency. This is the treatment for that condition. So you go on this because your body's not able to transport glucose, and there's a few other ones that are listed there. Pyruvate dehydroxygenase complex deficiency. So these tend to be first-line treatments. When we're evaluating patients with that, we do a metabolic workup to make sure that they don't have any kind of underlying metabolic issue that either is not appropriate for them to be on the diet, or if we find something, for example, like a GLUT1 transporter deficiency, then we know that they're going to respond. Children typically have daily seizures. You don't have to have daily seizures in order to go on the diet. Some kids that we evaluate have seizures every few days, every few weeks. But for the most part, we have kids who are very refractory, meaning they don't respond to antiepileptic medications. They become resistant to them, and so they are having seizures all the time. And they're starting to use, again, the diet in the United States. Johns Hopkins, they have an adult ketogenic diet clinic, and I think there's some interest perhaps in Ontario because we have a lot of patients that are going to be transitioning to adult care. The diet has been working very well for them in managing their seizures, and we're also using the diet for more serious cases like status epilepticus. We've had some success with that. So there's more attention being paid to the efficacy of the diet because it really is quite effective. So the next slide, we talk about effectiveness. Usually we say that children who respond to the diet will often see an improvement or a reduction in seizures within 3 months of trying the diet. There's a lot of tweaking of the diet when you first start it because your body is adjusting to metabolizing glucose to metabolizing fats. So it requires some adjustment and a lot of tweaking, and you don't start on the highest diet fat ratio. You start with a lower fat amount and work your way up to make sure you can tolerate it because you can have some side effects. The oil can cause diarrhea. You can have reflux. We just want to watch that very carefully. And there have been studies, and I haven't put their exact references. These are just kind of generalizations. that have reported there's a greater than 50% reduction in seizure reduction in more than 50% of children who are treated with the ketogenic diet. And one randomized controlled trial found that 38% of children that were treated with the ketogenic diet had a more than 50% reduction in seizures, while 7% experienced a 9% reduction in seizure frequency, and 7% had a greater than 90% reduction. So on the next page, we're going to, or the next slide, I should say, 50% of children will have at least a 50% reduction in seizures. 25% will have a 90% reduction, and 75% often have their medications reduced, and this helps to prevent the side effects of the medications, and it also helps with growth and development as well. We have some kids that are seizure-free as well, but you can imagine if you're seizing all the time and you experience even a 50% reduction, that's a huge, tremendous change, and that can impact growth and development and quality of life. So the next slide we have is, how do I start the diet? Well, you want to talk to your child's neurologist. We have lots of people who are very savvy. They go on the internet and find information and want to start the diet, but you have to have a conversation with your neurologist first to make sure that your child has had appropriate trials of treatment. And then if your child has intractable seizures and they, again, haven't been successful with medications, at least 2, and we want to make sure that they don't have any seizures or lesions or that would render them to be a surgical candidate. That's really important to rule out. So if they're not a surgical candidate, then they're a candidate potentially for the diet. But there's a few other things that we have to look at. So we ask that a referral is made to a diet center. And in the next slide, you'll see the process. Once a referral is made, then the child will come to the different centers. At Sick Kids, we have a keto team made up of dietitians. We have a nurse. We have a couple of neurologists, as well as myself as part of the team, and their social worker, who is very critical to our team as well. And what we do is a typical history and physical examination. We'll do a diet history, which is really important. We want to see how children are eating, and if they have poor feeding patterns. Sometimes we send them home with a little bit of homework to say, try and reduce the sugars. And if they have high carb intake, we'll try and give parents some exercises to try and cut down so that their children get used to not having diets that are predominantly on, say, for example, finger foods like chicken fingers and French fries. We also do a financial assessment because some of the products for the diet are expensive and they're not covered under the Ontario Drug Benefit Program. So that's key to find out as well too, because then we'll do applications for coverage or find out how we can try and get coverage for that. And feeding history is really critical. Our dietitians want to know if there's a history of any aspiration, if kids are having difficulty controlling their secretions. If there's poor oral intake, some children don't have adequate diet intake. They have poor fluid intake, and you have to have a minimum fluid intake also because the diet can cause kidney stones. So you want to make sure you do that. And we're also concerned if a child has reflux, because if they have reflux, you know that when you add fat, if you eat a fatty food, you often get heartburn. We can make it worse. So we like to have that managed and maintained before starting. And any further investigation, so if a child hasn't had adequate investigations yet completed, we want to make sure they have had an MRI, that they've had some metabolic studies and genetic studies as well. And then they'll be put on, if there's a bit of a waiting list, and then plans will be made for diet initiation. So the next slide you'll see, there are, I think, about 5 keto programs in the province of Ontario. The center, have a keto program, whereas previously they didn't. So this is good news for patients to, and of course there's some interest in doing it in adults. So there's sort of talk of potentially maybe having clinics in some of the major adult centers as well too. But that's under work, so that's something that we're going to also be advocating, because we'll have a lot of patients who remain on the diet. And then lastly, there's resources that you can look into. There's, on the last page, you'll see there's a book that's been written by, you've probably heard of Dr. Eric Kossoff, who is a major keto diet researcher, and he's at Johns Hopkins, where that's the center where they've done a lot of diet work. So they have this is a book. It's roughly $24. You can get it on Amazon. There are lending libraries that have them. You can go to your local epilepsy associations. They often have them. Sick Kids, we have a resource library with 14 copies. It's a very interesting read. And then there's different websites, including the one from Sick Kids, which is a comprehensive website that talks about different treatments for kids, including the different keto diets. And there's like a little video that one family is describing their experience as well, too. And that's it.
Well, that's terrific. Thank you very much, Priya. Very
No
comprehensive.
problem.
So we do have a few questions, and we have some time. So I'll read out the first question. I think, Dr. McLachlan, it's directed to you.
Okay.
I'm a community support worker, and I get a lot of questions about medical marijuana, particularly in light of the news reports about Charlotte's Web. What should I recommend to adults with epilepsy and parents of children with epilepsy who ask me about this?
Oh,
Well,
who are you throwing that one to? Oh.
You're throwing that at me?
Yes, Dr. McLachlan, yes.
Okay. Well, you're not the only one that recently is getting a lot of questions about using marijuana for epilepsy. I just gave a talk on this a couple of days ago, as a matter of fact. The interest has developed because, as you say, this Charlotte's Web, which is essentially a marijuana in oil form, so it's taken orally, that has apparently very good effectiveness in a rare genetic condition called Dravet syndrome, which causes a terrible seizure disorder in children. And there have been a number of anecdotal reports of this marijuana oil effectively reducing or stopping the seizures in these children. Cannabis or marijuana has actually been used to treat epilepsy for probably a few hundred years. The problem is that, unlike all the other treatments that I talked about earlier, there is no scientific evidence that cannabis or marijuana is effective for seizure control. That doesn't mean it may not be effective. It's just that there's no scientific evidence for it, and the way we develop treatments for any medical condition these days is based on scientific evidence. So under controlled circumstances, giving people with epilepsy, in this instance, marijuana, and determining does it decrease or stop seizures or not. There was a fair amount of research going on about this back in the 1960s and 70s in animal models of epilepsy, with some evidence that yes, indeed, marijuana does decrease seizures in these models. But then the regulatory agencies effectively shut down all research on marijuana, so there have been no clinical trials of that particular drug in people with epilepsy. So we don't know whether it works or not. there's a lot of anecdotal reports. I hear patients of mine telling me all the time that yes, I smoke marijuana and it helps my seizures, but that's not scientific evidence. So I think you asked what do I tell people who come and ask for marijuana. I tell them to go to the Health Canada website. So if you Google Health Canada and marijuana, it'll take you to their webpage. The government has recently changed the rules about medical marijuana, which is legal in Canada, and it's legal for certain conditions, epilepsy being one of them. And it'll give you a whole bunch of information about using medical marijuana for epilepsy. Does it work? I don't know. It might. I'm certainly not against people using it because it's relatively safe in that the chance of getting bad side effects are probably smaller than many of the drugs that we already use. So from that standpoint, I don't have a big concern. But some people are concerned about adverse effects from marijuana. So that's all I'll say about that.
Great, thank you. Certainly a topic that's been in the news a lot. So, go ahead.
Can I just add to that? Because we get that all the time at SickKids, and I agree with what Dr. McGonigal says. We're looking at doing a clinical trial at SickKids, so we're working on that. And there is actually a clinical trial that's happening at New York University with Dr. Oren Dubinsky. And they have it's a multi-centric study. They also have one going at UCSF, and it's a pediatric trial. We're waiting for some preliminary data that comes out of that trial. There was also a conference that I attended in October. So we're also telling families that we don't know right now how to treat with that. And we're encouraging, if there's a clinical trial, it's best to get research evidence, because exactly as Dr. McLachlan said, there's nothing right now in the literature that supports it that says that this stops seizures. So it's best to do it in the context of a clinical trial where you're eliminating bias, and you can do it under scientific conditions that are really going to give you the answers to those questions. Sorry to interrupt.
I can just add one other thing that we recently assessed the patients admitted to our epilepsy unit here, and roughly a third of them are using marijuana regularly.
Are they? Wow.
Well,
that's in the adult population.
Mm-hmm.
Good news to hear. Thank you. We look forward to hearing what comes out of those clinical trials, Maria.
Okay.
Dr. McLachlan, the next question is, what do you see as the most promising treatments on the horizon? Medication, surgeries, or something else altogether?
Let me put on my magic hat here. I think the next question kind of asks about that same thing in a different way of do we foresee the ability in the future to more effectively determine the root cause of epilepsy, and I'll tie those two together. If I had to guess, I would say that at some point one of the researchers who's studying the mechanisms of epilepsy and the mechanisms of seizures is going to come across something that will lead us to a more effective treatment. That's happened to a certain degree in the past, but not in a major way. But one of the reasons that many people are doing research into epilepsy and its causes is just that, to hopefully come up with something that will then lead to a much more effective treatment. And will that happen tomorrow or in 20 years? Could be either. I think that's the most likely way we will go here. Otherwise, what we're looking at is variations of the kind of treatments that we already give, the mainstays, with all due respect to the ketogenic diet, being medications and surgical management of various types.
Very good. We have time for one more question. Someone has actually emailed me a question. And one of the questions we have here is anti-epileptic drug side effects can be quite severe. When is it necessary to go back to the doctor?
Well, I tell people that if you're having any trouble at all that's bothering you, then you should contact the doctor. There are some people that are willing to put up with more side effects than others as long as their seizures are controlled, whereas others, you know, don't want to sacrifice, say, having to sleep for 2 hours in the afternoon to maintain control of their seizures. The aim is, the ideal is to have no side effects and no seizures, and I think that's what everybody should aim for. So even if your seizures are controlled and you're still having unwanted side effects, I think you should talk to your doctor about looking at alternative treatment.
Okay, great. Well, we've just about run out of time now, and first of all, I want to say that I found tonight's webinar, Dr. McLachlan and Maria, very informative, and I want to thank you both very much for giving of your evening and for sharing your expertise with all of us here tonight. I would like to remind everyone that they should connect with their physician about specific medical information, or you can also contact your local epilepsy agency for any other information and support. And you can find them by visiting our website at epilepsyontario.org. And finally, we'd like to remind everyone that our next webinar will be on May 22nd, where Dr. Brent Hayman-Abello will provide information on memory and epilepsy. So thank you very much, everyone, for joining us, and I wish you all a very good evening.
Good night.
Good night.
Good night. Good night. Thank you.